Hi, class. This is Dr. Weaver, and I wanted to go over some of the slides that I have developed for you all regarding care of patients with problems of the thyroid and parathyroid glands. I did mean to go over some of this information with you in class, but of course, it seems like when we take a test, we get kind of caught up in the test. Something I'm going to have to kind of get us away from. Um, but I do think it is important for us to go over some of these health concerns with respect to the thyroid and the parathyroid gland. I will be uploading this information to the cloud and will also provide you with, of course, the my username and password so that you all can access the information. So if you're listening to this presentation, then you are obviously already there. So on this next slide, I would like you to go ahead and read the objectives for this course, for this class. I won't read them to you. Please go ahead and take a look at each one because this is what I would expect you to be able to do by the end of this presentation. So the priority concept in this chapter is cellular regulation. The cellular regulation exemplar is hypothyroidism. The interrelated concept in this chapter is nutrition. So the thyroid gland is it is essential to the endocrine system and is actually a part of the endocrine system. It is located in front of the neck and it is responsible for the production of thyroid hormones. The thyroid gland releases hormones such as T3 as well as T4. These hormones play an important role in regulation of our weight, energy levels, internal temperature, skin, hair, nail growth, as well as many more. Now, hypothyroidism is what it basically means is there is an increased thyroid hormone secretions from the thyroid gland. Now, once patients have signs and symptoms from hypothyroidism, it is referred to as thyroid toxicosis. This condition can be either temporary or permanent. Now, all body organs are impacted by thyroid hormones by increasing the metabolism, resulting in certain signs and symptoms, depending on the organ. Now, when thyroid hormones are in an excessive amount, most body systems will react by causing a kind of hyper-metabolic state. What this does is it leads to that sympathetic nervous system activity that, remember, we talked about with heart failure. Now, what I would like for you to do is also to read chart 63-1, located on page 1265, for effects and signs and symptoms of hypothyroidism that it has on each system. So you'll see each system broken up, cardiac, and others and whatnot. You should be able to see the impact that hypothyroidism has on these different systems. Now, thyroid hormones produces a kind of hyper or overactive response. The hormones, they stimulate basically, so there's an increase in the patient's heart rate, their stroke volume, which is SV. And because of this, the cardiac output will be increased We talked about this, remember, that blood pressure would be also increased, and blood flow is increased as well. Now, elevated hormone levels, they do affect protein, fat, and glucose metabolism. Now, protein buildup and breakdown in hypothyroidism, proteins is built up and is also broken down. But the breaking down aspect is much greater than building up. So these patients become more less muscular, if you will, because there will be a loss of proteins. And this is essentially what we refer to as a negative nitrogen balance, because when you have less proteins on board, you are in a negative nitrogen balance. Now, with increased thyroid hormones, these patients are not able to tolerate glucose utilization very well. So the cells are not normally using the glucose. In other words, it actually leads to hyperglycemia. So the blood sugars will be elevated with this condition. Now, there is metabolism of fats, increase resulting in also decrease body fat. Again, there's a metabolism of the fat, and this does lead to a decrease in body fat as well, because it's being just burned up during this hyper active response. These patients are burning up lots of calories, and they become very hungry. The rate of burn is so significant that they still lose weight despite their eating efforts. And this leads to essentially a nutritional deficit. A stimulation a hormone produced or secreted by the hypothalamus of the brain and also the anterior pituitary glands causes thyroid hormones to be produced. So remember, the pituitary gland is actually situated just beneath the hypothalamus of the brain, and it is this stimulatory type of mechanism that actually causes your thyroid hormones to be increased. Because there is overproduction of thyroid hormones, the stimulation of hormone from the hypothalamus of the brain, as well as the anterior pituitary glands, changes or decreases in this sense because it is detecting an increase in thyroid hormone levels in the blood. So in other words, the hypothalamus of the brain and the anterior pituitary glands is saying, why provide stimulation to produce thyroid hormones when too much or enough is already present in the bloodstream? So we refer to this as a negative feedback loop. So when the body detects that there is enough hormones in the system, then this negative feedback loop will kick in and essentially will stop producing the hormones. Now, a negative feedback loop occurs in biology, in humans, or any biological beings, when the product of a reaction leads to a decrease in that reaction. So again, when the body detects there's enough hormones, then it will tell the hypothalamus and the anterior pituitary gland to stop stimulating more hormones. In this way, a negative feedback loop brings a system closer to a target of stability or homeostasis, so it doesn't require more when it has enough. Other systems affected by the thyroid hormone, such as having influence over sex hormone production. Some women have menstrual problems or decreased infertility. Um, this condition also increases sexual libido as well. Now, as far as etiology and genetic risk, hyperthyroidism has many causes, one of which is Graves' disease. It causes Graves' disease. Um, and also, it is known as toxic diffuse goiter. You see these large necks that some of these patients might have. Now, Graves' disease is also an autoimmune disorder due to what is called Hashimoto's thyroiditis, or HT. And what happens is it produces antibodies to attack itself. All right. These autoantibodies is produced and they work against a variety of substances within the thyroid gland. Um, An autoantibody is essentially an antibody produced by the immune system that is directed against one or more of the individual's own proteins, basically. The antibodies called TSIs attach to the TSH receptors on the thyroid gland. And this leads to an increased number of glandular cells. This will also in turn lead to an enlarged thyroid gland, forming again what is known as a goiter. Now, this will also lead to an increase of production of thyroid hormones, or also known as thyrotoxicosis. Now, this condition results in that sympathetic nervous system activity or response that we talked about. Now, Graves' disease has the same signs and symptoms of hypothyroidism, plus it results in exophthalmos, is what we refer to it as, or that protrusion of the eyes. And you'll see this in some of the upcoming slides where the patient's eyes are just bulging outward. Also leads to pretibial maxedema. And what this looks like is the skin around the tibial area is dry, waxy swelling from the lower limbs of the lower limbs, which looks like benign tumors or keloids actually. So hyperthyroidism can also be due to multiple thyroid nodules called toxic multinodular goiter, meaning the nodules are enlarged thyroid tissue or benign tumors, so they're not really cancerous. We talked about the exophthalmos or protrusion of the eyes, and the again, I don't know why I duplicated this, but the pretibial maxedema. I'm sorry, let me go back. So basically, when I talked about the toxic multinodular goiter, so with this one, you won't see the maxedema. That's why I wrote that. You won't see the maxedema, and you won't see the protrusion of the eyes or the exophthalmos in this particular condition. That is the multinodular goiter. You won't see it in that. Let's see. So hypothyroidism can be due to excessive use of thyroid replacement hormones, or also known as an exogenous hypothyroidism. So when these patients are on replacement therapy, if they're given too much, they can also have hypothyroidism as a result of that. As far as incidence and prevalence, women are affected more than men. Now let's go into interprofessional collaborative care. Um, this condition can be managed in the community, but at times in the acute care setting, especially when a complication called thyroid storm develops, and we'll talk about that as well. As far as history is concerned, when you are talking to your patients and you're getting a history from them, the patients might report unplanned weight loss. Remember, these patients are just burning up everything. There's an increased metabolic rate that does affect nutrition. There's a decrease in appetite. And these patients are also having increased bowel movements daily. Now, the hallmark of hypothyroidism is heat intolerance. So in other words, these patients have increased sweating, even if environmental temperature is comfortable for mostly other people. They will actually be sweating when you're comfortable. And again, that is a hallmark, a sign of this condition. These patients, they might be seen wearing light clothing, even in cold weather, because they're not cold. With this increase in metabolic rate, actually produces a lot of heat. So again, these patients are sweating quite a bit. Also read chart 63-1 on page 1265. Four effects of, and I think I gave this to you, four effects of effects and signs and symptoms of hypothyroidism that it has on each system. And this will pretty much guide you on what to look for. You also want to ask patients about previous thyroid surgery or if they've had radiation to the thyroid gland. Also want you to look at figure 63-2 on page 1266 for a picture of that goiter I was telling you about earlier. The thyroid gland may increase about 4 times the normal size. You may also take the bell of your stethoscope and hear what we call bruits in the area near the thyroid, which is basically turbulent blood flow heard by a stethoscope will be present as well. Now, as far as psychosocial assessment, I want you to read chart 63-1 and look like I cut off what number is 12. It might be 1265 or 1266. Again, for your psychosocial signs and symptoms as well. And here's the exothalamus that I was telling you about. Look at the eyes. All that tissue is behind the eyes and making it bulge outward. So just take a look at that. So here's a picture of a goiter that I discussed with you. The key difference also, just want to discuss a little bit about positive and negative feedback. The key difference between positive and negative feedback is their response to change. Positive feedback amplifies a change or brings about more change, while negative feedback, it reduces the amount of hormone in this case, or reduces change. So this means that positive feedback will result in more of a product, more apples, more contractions, or more clotting platelets. But once enough platelets are produced, then the negative feedback will kick in and says, stop. So some of the, the laboratory tests that you will see with these patients, we have, well, when you're testing for hyperthyroidism, lab tests might be your T3, T4, as well as TSH. Now, for Graves' disease, antibodies to TSH receptors are measured. Remember, Graves' disease is an autoimmune disorder. I want you to also take a look at page 1267, chart 63-2. For what thyroid labs will look like. There'll be increase, decrease, depending on whether you have hypothyroidism versus hyperthyroidism. Um, for example, serum T3 is increased in hyperthyroidism and decreased in hypothyroidism. Another test that is used, but not as much, is the radioactive iodine, or 123I. Also, you may see RAI. This substance is given to these patients by mouth, and uptake of this iodine is by the thyroid gland itself. The thyroid gland actually takes up this iodine. This is not to be done in a pregnant woman, woman, by the way. Now, the half-life of 123I is short, and the normal uptake of iodine by I guess you could say a normal thyroid would be 5 to 35% in 24 hours. But now in patients who have hyperthyroidism, this 123I uptake is much faster. It's basically identified as an active thyroid, so you know that they might likely have hyperthyroidism. This is not a common test that is used anymore. Other tests use thyroid scans. This evaluates the position, the size, and function of the thyroid gland. There's also the ultrasonography, and this looks at the size and general composition of masses and nodules. So what does the mass and the nodule consist of? And also, because cardiac events are common in patients with hyperthyroidism, an ECG might show SVT, atrial fibrillation, dysrhythmias, and also PVCs. So as far as interventions are concerned, the most common interventions are drug treatment and also radio ablation. Now, surgery is typically a last resort for more severe disease that doesn't respond to conservative treatment. Now, the goal is we want to decrease the effect of thyroid hormones on the cardiac function or system. We also want to decrease thyroid hormone secretions, because remember, they're producing quite a bit. As far as nursing focus or priorities of care, we want to monitor these patients for complications like dysrhythmias. We also want to decrease stimulation as far as their environment is concerned. So basically, dim the lights, make sure there's a reduction in noise and so forth. We also want to increase their comfort level. Remember, they're sweating profusely, so we want to make sure we're not covering them with a whole lot of blankets and whatnot. Drug therapy is also important to teach patients and families, particularly about the side effects and proper administration. We want to monitor their vital signs at least every 4 hours. And we want patients to report if they are feeling palpitations, shortness of breath, vertigo, or chest pain. Report this immediately to the physician. Also report increasing temperature, as it might be due to impending thyroid storm. And thyroid storm is a life-threatening event from uncontrolled hypothyroidism. And this has signs and symptoms of high fevers, severe hypertension. Now, if the temperature increases by 1 degree Fahrenheit, report immediately, and that immediately is in caps. If the temperature also increases, you also want to check their cardiac status for dysrhythmias, because that is a time when you are likely to see dysrhythmias. As far as drug therapy is concerned, these patients will be on anti-thyroid drugs. They are initiated, and once they're initiated, rather, they can result in remission for as long as about 10 years. I want you to also look at page 1268, chart 633, for teaching priorities for patients receiving drug therapy for this disease. Common drugs that you might see for hypothyroidism is tapazole and also PTU. The latter is used less due to liver toxic effects. The drugs work by blocking thyroid hormone production by preventing iodine binding in the thyroid gland. So it will not allow iodine to bind to receptor cells in the thyroid gland itself. Effect of the drug can be slow due to the excessive amounts of hormones stored in the patient's body. So be aware that it's not an immediate fix for these patients. Now, iodine preparation is used for short-term treatment before surgery, and its action is to decrease blood flow to the thyroid gland. And with a decrease in blood flow to the thyroid gland, this will result in a decreased production and release of thyroid hormones. And with this treatment, short-term treatment, these patients might see results in about a couple of weeks. But it takes longer for the metabolism to actually return to normal. These patients must be watched after you give this particular preparation for hypothyroidism, so they will begin to go the opposite direction. And so look for hypothyroidism signs and symptoms. There's also Enderol, which is a beta adrenergic blocking drug. This is also used to counteract signs and symptoms that are brought on by that sympathetic nervous system activity. That is the diaphoresis, the anxiety, the tachycardia, and palpitations. So these drugs are used in this case as only supportive care, but it does not inhibit or decrease hormone production, so it's just more supportive in helping to minimize symptoms, in other words. Now, the goal of supportive care is to prevent or treat as early as possible the symptoms of this disease and the side effects caused by treatment of the disease as well. And also psychological, social, spiritual problems related to a disease or its treatment. Also, we have to make sure we consider comfort care, palliative or comfort. Palliative is actually comfort care for these patients, and basically symptom management. Now also look at page 1269, chart 63.4 for precautions to teach patients during the first week after receiving the 131I. For example, males should sit when they pee in order to avoid splashing. Now, this is when we talk about the 131I, we're talking about this radiation. So you don't want the male peeing standing up, because when the water and the pee, of course, from the commode splashes, it can get on the seat and the walls and the floor. With this potentially radioactive material contaminating that area. Some radioactive treatment can lead to hypothyroidism, in which case the patient would need thyroid replacement treatment for the rest of their lives rather. So we are monitoring the thyroid function regularly when this occurs. Now, yeah, so again, I did talk about reducing stimulation, so encouraging rest, providing a quiet environment, limiting visitors, postponing non-essential care and treatment. So if there's any kind of care and treatments that can be postponed, don't hesitate to do that, especially when, again, it's non-essential. As far as promoting comfort, we want to decrease the room temperature as the patient has heat intolerance, provide the patient with fresh water, dry sheets as these patients, they sweat a lot, and also providing a cool sponge bath several times a day, and of course the UAP, unlicensed assistant personnel rather, can perform many of these tasks. And of course, we talked about the drug therapy. Now, as far as surgical management is concerned, for patients with Graves' disease that didn't respond to conservative treatment, these patients might end up having a total thyroidectomy, which is removal of the entire thyroid gland, or subtotal thyroidectomy, which means a partial removal of the thyroid gland. If an enlarged thyroid causes a tracheal or esophageal compression, surgery will certainly be needed. Now, removal of a thyroid means that there would be a decreased production of hormones, and these patients will require lifelong replacement treatment. As far as in the pre-op phase before surgery, these patients will have treatment of a drug called thionamide to induce what you're trying to do is bring about a near or normal thyroid function, or what we also call euthyroid before surgery. So we want to get the thyroid as near normal before surgery as possible with this particular drug. Some iodine preparations also used to decrease thyroid size and the vascularity. And of course, when you decrease the vascularity, blood vessels, this can lead to decreased bleeding and potentially thyroid storm during and after surgery. Conditions such as hypertension, dysrhythmias, and increased heart rates must be controlled before surgery as well. So they can't go into surgery unstable. These patients might need to follow a diet high in proteins and carbohydrates days or weeks before surgery, and this is to kind of get them more tuned up for the surgery. These patients should be taught, again, in the pre-op phase, coughing, deep breathing. They should be taught to support their neck or splint the neck by placing both hands behind the neck to reduce strain on the incision. Inform the patient that he or she is likely to be hoarse due to oral intubation, but that should subside in a few days. These patients will also have a drain after surgery. Now, during surgery, the parathyroid gland and the laryngeal nerves are avoided in order to decrease complications or any injuries. Now, as a special note, for patients who have a subtotal thyroidectomy, meaning, remember, part of the thyroid is removed, not all of it. So the remaining thyroid tissue is actually sutured to the trachea. For the total thyroid type, the entire gland, as I mentioned, is removed. However, the parathyroid gland is left in place with an intact blood supply in order to prevent hypoparathyroidism. Now, as far as the post-op complications, these patients you want to observe for complications following surgery. We're observing their vital signs frequently. Um, Post-op complications must be identified early. These patients can die on you. These patients are placed in a semi-Fowler's position. Um, we must support their neck and their head and avoid positions that might place their neck in an extension position. Hemorrhage or bleeding is likely to occur within 24 hours after surgery. And so as nurses, we must assess the neck dressing and also behind the neck for pooling, blood pooling. Um, as far as the drain is concerned. I mean, the drain may not be catching everything, so the patient might have a pool of blood in the back of the neck. So you want to make sure we're taking a look at that as well. Now, a moderate amount of serosanguinous drainage is expected, and that won't be an issue. We must look for bleeding at the surgery site. We must look for tracheal compressions as evidenced by respiratory distress. So if the trachea is compressed, the patient will be in distress. As far as respiratory distress, there's a possibility of respiratory distress with decreased gas exchange, and this can result from swelling, from a condition that we call tetany, meaning these patients have low calcium levels as a result. So it's possible the parathyroid gland was affected. There's also a possibility of damage to the laryngeal nerve due to spasms. So we must look for acute respiratory obstructions, and that is also known as laryngeal stridor. And take a look at a YouTube video and listen to what laryngeal stridor sounds like. Some of you have probably heard of that before. We must also keep emergency trachea equipment at the bedside always, along with oxygen and suctioning equipment. Injury to the parathyroid gland can lead to, this is something I just discussed, but it can lead to hypocalcemia and a condition again called tetany. Now, this tetany, this latter condition here, you will see hyperexcitability of nerves, muscles from low calcium. Now, hypocalcemia and tetany happens when the parathyroid gland are removed or damaged, or if there is a decreased blood supply to the gland during surgery. This can lead to decreased parathyroid gland hormones levels called PTH, and you'll learn about hypoparathyroid issues as well. To assess for this complication, you want to ask the patient hourly about tingling around the mouth, around the toes, around the fingers, and this will alert you to the fact that the patient is experiencing tetany. We also want to assess for muscle twitching, and again, this is a sign of low calcium, of which these patients will be given calcium gluconate or calcium chloride. Take note that this is an emergency, a medical emergency. The laryngeal nerve damage. Damage results in these patients becoming hoarse. Their voice might be more weak. So the nurse should assess their voice quality at least every 2 hours. Now, thyroid storm or thyroid crisis, for that information, I want you to look at page 1270, chart 63.5 for emergency care for patients during thyroid storm. Now, Thyroid storm is a life-threatening emergency due to uncontrolled hypothyroidism, such as from Graves' disease. These signs and symptoms, they do develop very quickly, and if left untreated, it will lead to death. Now, thyroid storm can result from trauma, from infection, DKA, diabetes, ketoacidosis, or pregnancy. Also can result from vigorous palpation of the aorta, so you want to avoid that as well. And also exposure to iodine and radiation treatment can bring about this complication. Signs and symptoms of this complication is caused by, again, excessive thyroid hormone release. And it leads to an increase or this out of control metabolic rate. So the patients will have signs and symptoms of fever, tachycardia, and systolic hypertension. Possibly abdominal pain, that NVD is nausea, vomiting, and diarrhea. These patients become very anxious. There's tremors. And remember, this is all a part of that sympathetic nervous system body's response. Everything is just hyper. Now, progression of complications leads to signs and symptoms of restlessness, confusion, psychosis, seizures, and coma. And these are more of the latter stages. Of course, you don't want any patient's condition to get to the latter stage if possible. Early detection is key. So the most important interventions is to maintain airway, promote ventilation and gas exchange. We want to lower the fever and stabilize their hemodynamics. As far as eye and vision issues of Graves' disease, it isn't actually corrected with treatment of hypothyroidism. But if the problem is mild, these patients can be taught to elevate the head of bed at night and to also use artificial tears. These patients who develop photophobia, they should be encouraged to wear dark sunglasses. And also at night, since their eyelids would not close completely, these patients can be instructed to tape the eyelids closed at night to minimize or to decrease dry eyes and to also prevent injury. Now, this PSI is pressure. So pressure around the eyes can cause, because remember these patients have the exophthalmos. So this pressure, the bulging effect of the eyes can result in decreased blood supply to the eyes, also ischemia and blindness. Steroids are given to reduce the swelling and to stop the infiltrative process that is happening with the eyes. Other treatments, there may be a combination of steroids as well as radiation. Surgery might be needed to decompress the eyeball to reduce loss of sight or damage to the eyeballs. As far as health teaching involves teaching patients about their disease, to report any worsening signs and symptoms, what signs and symptoms to expect. There's also the need for hormone replacement treatment for life in most cases. And also we must ensure patients understand the importance of follow-up as hypothyroidism may occur with treatment of hyperthyroidism. So on post-op monitoring, I kind of got ahead of myself. So just refer back to the previous slide about the hoarseness, stridor, suture line pressure, hypocalcemia, and tetany. as well as thyroid storm. So again, just refer back to the previous slide, of which I discussed this information already.